Hey folks, Chadi Nabhan here with the Hem-Onc Pulse and Blood Cancers today. I'm here on site at the American Society of Clinical Oncology meeting in the beautiful city of Chicago. And alongside me is Dr. Neha Mehta-Shah. Welcome to the Hem-Onc Pulse and Blood Cancers today. Thank you for joining me today. Dr. Mehta-Shah, just tell us a little bit about your practice, where you practice, and what you do.
Sure, thank you so much for having me. It's really a pleasure. I'm an associate professor of medicine, only treat lymphomas at Washington University in St. Louis, where I focus on aggressive and indolent lymphomas, but predominantly aggressive lymphomas.
That's great. Well, there's, we made it to a plenary session
Yes.
at ASCO,
Yes.
right? It's not we're not going to go into lymphoma, solid tumor or not, that's okay. But we made it to the plenary session here. Tell us about what the buzz is all about with this plenary presentation, and let's break it down to our viewers and listeners.
Yeah, so S1826 was a U.S. intergroup study, a collaboration with the Alliance, ECOG, led by SWOG, and also the Children's Oncology Group and the Canadian Oncology Groups, all together working to try to solve the question of can we improve outcomes for patients with Hodgkin lymphoma in the advanced setting. So patients who have stage 3 or stage 4 classical Hodgkin lymphoma who need treatment. And the study accrued 1,000 patients, kids and adults, with the largest Hodgkin lymphoma study done. And done in record time, so a year ahead of schedule, in large part due to this collaboration across the intergroups. And the question was, can we improve upon brentuximab AVD? So brentuximab AVD was shown to be superior not only in progression-free survival, but then overall survival, as you know, compared to ABVD, which had been our standard of care in the study Echelon 1. And therefore, I think once there was a survival benefit, most of us adopted giving brentuximab AVD to our advanced stage Hodgkin lymphoma patients who could tolerate it. But the tolerance is an issue. Most patients have peripheral neuropathy. That neuropathy can be quite debilitating. Patients are getting brentuximab AVD, which requires growth factors, and because so many of these patients are young, they do have a significant amount of bone pain associated with the growth factor injections, not to mention that also adds cost. So the question was, can nivolumab AVD do better than brentuximab AVD?
And why nivolumab was chosen?
Yeah, so nivolumab, as you know, has been approved for relapsed refractory Hodgkin's lymphoma for a number of years. There's a putative mechanism for that we know that the Hodgkin lymphoma genetics lead to an overexpression of PD-1 due to abnormalities in chromosome 9. And that's been known for many years since the development of checkpoint inhibitors in Hodgkin lymphoma, making them particularly sensitive, to PD-1 inhibitors. And then came studies of adding nivolumab or other checkpoint inhibitors to standard chemotherapy in the relapsed refractory setting, showing that as in combination with chemotherapy like ICE or GVD, standard relapsed refractory Hodgkin lymphoma regimens, that they improved outcomes, and those patients who received those therapies who go to autologous transplant had much improved outcomes compared to what we had seen previously. So it was seen that there was probably a synergistic effect of giving PD-1 inhibitors to chemotherapy, specifically in Hodgkin lymphoma, which was what led to this study that was led by Alex Herrera.
So the study was comparing BV AVD versus NAVD?
Exactly, and 6 cycles of therapy, and everybody was given therapy on the same schedule, and it was not blinded, so patients and investigators were aware of what arm of the study that they were on. And the study was written to read out at least its initial results after a certain number of events had been reached. And we were very excited that this winter into spring, we learned that the 1-year PFS was superior of Nivo AVD compared to BV AVD, 94% versus 86%, which is kind of remarkable.
Is that the primary endpoint, or
the endpoints of the study will be in progression-free survival overall, but and then they'll also be looking at overall survival for certain, and then there's a number of correlative, secondary exploratory endpoints looking at cell-free DNA and metabolic tumor volume. But I think, one, just the numbers are very impressive. We're living in a world where patients with advanced stage Hodgkin lymphoma, 1 year after they finished, 1 year into their treatment, have the vast majority of them are living disease-free, which is, I think, a big achievement compared to the world I lived in even when I was a resident or a fellow. But then on top of that, nivolumab AVD was certainly less toxic. So there was less, while there was slightly more neutropenia seen, those patients did not require growth factors. So, and there was less actually febrile neutropenia.
I was going to tell you, one of the things that we are always challenged with the Hodgkin lymphoma is elderly Hodgkin lymphoma, the older patients. So I wonder if you can break down, did this allow us, are we able to safely do NAVD in older patients?
Yeah, so this study enrolled patients who are older, and there was even thought about expanding a portion of the study. That talk is still ongoing about expanding it in the older population specifically, because nivolumab AVD was certainly very well tolerated and tolerated amongst the older individuals. And the benefit of Nivo AVD was seen more in, if you look at the forest plots, in all patients, but certainly with a high level of confidence in the older patients over 62.
So the study is going to be followed for overall survival?
Yes.
So practice changing? Tomorrow you see a Hodgkin lymphoma patient. Are you ready for NAVD?
I was just having this discussion. I have a patient who's 65 with, that we found out last week, the pathology resulted in Hodgkin lymphoma. And the question is, if I have access to nivolumab AVD over brentuximab AVD in that patient, that I would consider giving it, because it's certainly
like an insurance issue right now.
Well, yeah, I think right now it's not. I think pending this presentation and more analysis, we'll have to see if it gets listed, for use in the NCCN, or how easy it will be to get a hold of it. But certainly once it's available to patients, we would strongly consider it.
I have to say that when you have such a strong data with BV-AVD, really congrats to all of the authors, investigators, collaborative groups, because to me it seems like, okay, it's great, it's not enough. Let's see if we can do better. So it's really remarkable results. And I think probably my last question is that oftentimes in these settings there are folks who would do these interim PET scans and try to see if they need to do anything. In that particular trial, or even moving on in your practice, would interim PET scans have any role here?
That's an excellent question. So the study did not require interim PETs for all patients. There were certainly providers who opted to do that based on their own preference. And part of that was because there was a thought with using nivolumab that patients may have PET avid responding disease, and it's unclear what that would mean or what to make of it. One of the really interesting things that will be looked at in this study is looking at baseline tumor metabolic volume as a predictor. There's good work from that was led predominantly by Alison Moskowitz at Memorial, looking at that as a predictor of outcomes in Hodgkin, and some of that will be looked at in this study as well.
This is really wonderful. I feel like we're probably going to beat the German Hodgkin lymphoma groups with the accrual, so we're doing very good. Congratulations to all of the lymphoma treating physicians and really the patients for these excellent results. Dr. Neha Mehta-Shah with me on the Hem-Onc Pulse and Blood Cancers Today on site at ASCO in Chicago. Thank you.
Thank you very much.